Welcome, everyone, to the Gender and Health Hub Virtual Forum, Evidence, Voice, Action, Catalyzing Change for Gender Equality in Health. My name is Sagri Singh, and I serve as the Chief Gender and Health at the International Institute for Global Health, which hosts this hub. We are a UN-affiliated think tank focused on evidence to policy translation in global health, working closely with partners across the Global South. A key stream of our work and a focus of this particular hub is to explore and distill how gender equality issues are integrated into health policies and health programs, particularly what works and what does not work. We focus on the how to do it, understanding that the what is already well covered. And we are particularly keen to unpack how gender equality is addressed at scale and in systems, recognizing, of course, that working with and for communities is critical to deliver on results. Through these next 3 days and 3 sessions, co-hosted with our multiple partners, we will unpack some of the key issues facing the field of gender equality in health more broadly, spotlighting the evidence, the practices, and most importantly, how best to act collectively on our expertise and learning to advance gender equality across the interconnected areas of people's lives, and particularly linked to health. Today, I am delighted to be sharing the launch of a case study summary series, spotlighting what works to advance gender equality in scaled government programs. The case studies were a joint effort of the University of the Western Cape School of Public Health and the Public Health Foundation of India, Ramalingaswamy Center for Equity and Social Determinants of Health. Both partners are here with us today, and they are co-hosting this event with us. I would particularly like to thank them and our colleagues at UNU-IIGH who have conceptualized, designed, and developed the project from start to finish and have also been instrumental in this session. I would also like to take this opportunity to thank our team at UNU-IIGH who have worked tirelessly to make the forum a success, Joanna, Arthur, Zaida, and our partners, Impact Basis and LBDC. While we are sharing the results here of the research, the process of collaboration for this project is particularly interesting. It was equitable right from the start, and I encourage you to check out our website to learn more about this process. Today's session, is in a webinar mode, but we do want to hear from you. So please put your questions for the panelists in the Q&A section and share your thoughts in the chat function. We will first hear from our opening speaker, Professor Naila Kabir, followed by Dr. Joanna Riha, a research fellow at UNU-IIGH, who will present findings from the study on behalf of the Regional Promising Practices Collaboration. We will then hear from the panel speakers for a 40-minute discussion, followed by a Q&A with all of you for about 20 minutes. If you find any discussion points interesting, please feel free to share it on social media with hashtag GHH Virtual Forum. Now, I'd like to take the opportunity to introduce Professor Naila Kabir, who is a professor of gender and development at the Department of International Development. She's recognized for her substantial contributions to gender mainstreaming and her work on gender issues and development, and is one of the pioneers in addressing gender inequalities systematically to create more inclusive and equitable governance structures. The UNU-IIGH team is delighted and lucky to have her as a member of our international board. Thank you, Professor Kabir. Over to you.
Thank you very much, and Sagri, and I want to say how pleased I am to be giving you some opening comments in this forum. I'm very pleased because I think this topic of health is extremely important, is one of the most important for a number of different reasons. We know of it in terms of a capability, in terms of livelihoods, how important it is, and how women have often fallen behind in labor markets and livelihood opportunities because of not only their own health, but the health of the family, the health of their children. They are primarily responsible. And we know, for instance, even in micro-level studies, the issues of own health, others' health is a major concern that stands in the way of women participating in the public economy. But I want to say one other thing that we sometimes overlook. Health is also about happiness. If you're not healthy, it's very hard to be happy. And I think in development, we tend not to talk too much about happiness. But I know when I'm not feeling well, I don't feel motivated. I don't feel well disposed towards people around me. And if we multiply that on a global scale, can you imagine how critical health is to growth, to welfare, and to human happiness? So I want to really kick off with that comment. What you're going to be talking about here, and I think it's absolutely, as you said, Sagri, what is known, but how to make it happen is the challenge, right? So we can sit and pontificate in offices about what we need to do, and then we go out in the real world and we meet the challenges of the real world, and then things are much harder. So I see these policy interventions that you're talking about as efforts to intervene in ongoing process of change, which might otherwise unfold as business as usual, with the patriarchal constraints, with the inequalities, with things that have been built into the way societies function, and which very often need these outside interventions as a form of interruption. No, it's not going to happen this way, because now we are going to provide these kinds of support. And so impact assessments of the kind of studies that you're doing are studies of interruption. How successful are you in shifting the trajectory of change from the one that it might have followed in the absence of any kind of external inputs to something that is more desirable? But in making that shift of trajectories, you're up against the barriers of the past and the present day norms, rules, all of these things that make it very difficult. It's when something goes against the culture. It's a countercultural change. So when people say these are not our cultural values, no, they're not. But we don't want to hang on to every single cultural value if it means denigrating certain sections of the population on grounds of their gender, their race, whatever. These are all cultural values, but we don't want to hold on to them. So what I think is very interesting about the studies, and I'll be fairly brief, is each of them, the case studies that you all have chosen, I think have been chosen very wisely, because each of them illustrates intervention at a different point. So when I look at the study of the right to safe abortion in Nepal, here is an interruption in historical processes that assume that women, particularly poor women, had to put up with unwanted pregnancies and perhaps unwanted children, even if it cost them their lives. And so likelihood of maternal mortality is so high in these poor countries because of this taken for granted assumption, this is a natural event, if they die, they die. And an unsafe abortion is a part of that process. So here we see in Nepal an intervention at the level of policy and shifting culture. And then we have examples of intervention in training medical and health professionals in Maharashtra, integrating gender sensitivity into curriculum to shift the values and skills of the people who are responsible for making sure that health and women's health in particular is critical. And we learn a lot about the ground level skills and mindsets that are important for these doctors, these professionals, to act on what they've learned. We see the example from Philippines of changing actual practices in Philippines, right? What you do. And I thought it was interesting that, I don't know which study it was, but you don't now have to require your husband's permission in order to access contraception and so on. And in Niger, we see efforts to change the values and attitudes of men. Huge, important partners in the whole project of greater gender equality, and perhaps sometimes underestimated or under-resourced because it's often quite difficult, because many men feel like they may have something to lose. But working with them, I think, makes it possible to shift those values. And in Ethiopia, we saw that the efforts that you all have investigated is two forms. One is a manual, change ideas, change practices, etc. And the other is practice. How do you change responses at the primary health level? And then I really thought was interesting, we know that women are not a uniform category. There is intersectionality. We know also that we don't go far wrong by focusing on those at the very bottom, because they are at the crossroads of all the different kinds of inequalities, whether it's caste, whether it's ethnicity, whether it's race, and now increasingly, whether it's gender identity and sexual orientation. So we also have a very progressive effort in Tamil Nadu with these gender guidance clinics, trying to address the health needs of the LGBT community in India, a group that we know has existed historically, but been marginalized historically. So I want to sort of end there, I think, with those comments. So I just want to repeat what I really like about the approach that you've taken is that it is a holistic approach. It looks at norms, rules, practices at the different levels, but equally it adds what we need to do better. That section on future challenges and opportunities is not, I think we learn as much from what we didn't do well as we do from what we did well. And I think being upfront and honest about what we could have done better is a hugely important part of the learning process. So I wish you all the best of luck. I look forward to reading more detail. I have read some of these briefs, and I think you have a lot to communicate to the whole health community and the development community. So goodbye.
Thank you so much, Professor Kabir, for those opening comments and for giving such a fantastic sort of snapshot of the different case studies, which we're so thrilled to be launching today. I'm Joanna Ria, as Sagri introduced, and I'm going to be sharing a brief presentation now with regards to the project and a bit more detail about the case studies and some of these findings. The slides that I'm going to be sharing are available in French and Spanish and will be dropped into the chat in case you would like to use them and look through them in those languages as well. Next slide, please. I wanted to start by really making the case and perhaps reinforcing some of the points that Professor Kabir already introduced in her opening remarks. And the current context in which we are in, I think, with various polycrises and a rising anti-gender movement, really means that we need to build on and continue to use the practice-based evidence that is available to advance gender equality in integration into health programs, particularly, following COVID and building back better. And at the moment, with regards to the evidence base that does exist, there is a sound and very robust evidence base, but often that is really centered on particular health issues, so sexual and reproductive health and rights, gender-based violence, for instance. And often the evidence is from much smaller scale, shorter term interventions in very controlled settings. And so there's a real need, as Professor Kabir mentioned, to understand on the ground what is happening in different contexts, and I think that's really critical at different levels, as she highlighted, but also looking at health programs that have been scaled and sustained and really involved government. And so that was really the context and prerequisite for this Regional Promising Practice project. Next slide, please. And the aim was to document and analyze and really unpack these key elements that drove scale and sustainability across specific cases where government health programs have successfully integrated gender. And so how was this done? I think Sagri very aptly put it in her opening welcome. This was a collaborative project through and through between School of Public Health, UWC, PHFI, and various other country partners that were involved. And what we did in terms of identifying the case studies, this project from the beginning has been very intentional and we aim to cast our net wide to be able to crowdsource and identify as many potential cases as possible. So we did an open call, a desk review, and followed up with key stakeholders and identified over 51 potential programs across Africa, South Asia, and Southeast Asia. However, as we dug deeper, fewer than 20 of these programs really had substantial government involvement or were active for longer than 3 years. So if we're thinking about the criteria of sustainability, for example, and few went beyond addressing health needs of a particular gender group to really address gender inequalities. And so what we ended up doing was selecting very carefully 6 case studies, as Professor Kabir highlighted in her opening remarks, spanning various geographies, but also at various levels. So we have the case study, the École de Marie in Niger, which looked to bring men into reproductive health programs. That was very much at the community level. At the institutional level in the Philippines, at Barrio Regional Hospital. There was gender integration and mainstreaming through and through in terms of that tertiary hospital. There are the gender guidance clinics in Tamil Nadu that focused on service provision to the transgender communities there. And then case studies at the systems level in Ethiopia that focused on providing gender-based violence services at the primary healthcare level. And in India, the gender mainstreaming and integration of gender into medical education and curricula in the state of Maharashtra. And finally, as Professor Kabir highlighted, at the policy level is the right to safe abortion in Nepal. And you will have a sense from the upcoming panel discussion of the different elements that play out at the case studies across these different levels. So we did in-depth interviews, document reviews, and also policy dialogues to really engage various key stakeholders. And I think this was a unique feature of the project, moving forward and building relationships with policymakers to further advance this agenda. Next slide, please. So what did we actually find? And I won't go into too much detail. I only have 10 minutes, but I did want to talk you through sort of how we analyzed and what were some of the key findings at different levels. And as I mentioned previously, the aim was to document key elements. So what was it that enabled these programs to be sustained and scaled with this focus of gender integration into a health program, a government health program? And we looked at some of these elements at different levels, at the contextual level, so thinking about what were some of the factors at national level, for example, supportive legal or policy frameworks that existed and were leveraged, perhaps active CSO engagement and movements. At institutional level, looking at what multi-sectoral collaborations existed or what forums were created to allow for multi-sectoral collaboration, across government ministries, for example, or engaging with key donors, and generation of evidence. Where was that evidence coming from? Was it locally generated? Was it drawing on evidence from what was happening in neighboring countries, for instance, or at an international level, and how that evidence was then leveraged to catalyze change and bring about gender integration into some of these programs and policies. So moving from the context, we then tried to unpack what were the catalysts. So in many case studies, it was really a key individual or a decision maker who understood the context in terms of the environment within a particular government ministry, understood sort of the levers and things to push or pull, as well as had links to funding and framing of the issue. And I think this is really critical in different contexts across the case studies. Issues had to be framed in different ways to bring people on board and move forward change. And I'm sure you'll hear more about that in detail in the panel discussion. And if you'd like to definitely read the reports. The next level, in terms of these key elements that we unpacked, were the mechanisms. And these were really things that helped institutionalize and sustain and drive the change forward over a prolonged period of time. So it was things like institutional policies or structures, training, as well as accountability structures that were set up in different ways, sometimes ad hoc. And I think this is where we need to look at where's their scope to improve. And finally, what were some of the achievements? And this project never set out to evaluate any of these programs. The aim was not to document the outcomes and the changes. It was about the key elements that drove the change. So very much focusing on the other layers, but recognizing through anecdotal evidence, through the interviews, as well as document reviews, what were some of those achievements from a gendered perspective. So obviously thinking about improved health outcomes, we have a health focus, but thinking about improved quality of care and provision of more gender sensitive or gender responsive healthcare. So next slide, please. I think I want to go on briefly and touch on why these findings matter. And I think this is a really important piece as we think about how to drive change in different contexts. And it's about tactics, better understanding how were some of the key elements I presented used in combination to broker change at different levels. And in many of these environments, I think, although we have this section that maps out some of the achievements, the successes may look small, but if we consider the context in which a lot of these case studies took place, it's hostile environments that push back when you're trying to advance gender integration. And so actually these small wins are big wins, and government systems, especially now, are resource constrained. They're cutting back. There's also bureaucracy. So as we think about, and as you're reading through some of the case studies and listening to the panel discussion, it's about what were the key elements that allowed for resilience, that allowed for resourcefulness, as well as accountability. Next slide, please. And I just want to spend a few minutes, and I think this is a really critical piece of our work as well, is recognizing what were the missed opportunities. And these are highlighted across the case studies because there's always room to improve. So thinking about the point of intersectionality and how different social dimensions of discrimination may be addressed through one particular lens, just looking, for example, at providing sexual and reproductive health services to adolescent girls, for instance, through a particular department, but not thinking about what does this mean, for example, for Indigenous women. How do those services need to be provided differently to this group, and the discrimination they may face when they come to access care. It's also, I think, the findings pointed to this point about connecting the dots and advancing gender integration, for example, in one area with the gender guidance clinics in Tamil Nadu, respectful care and training providers on issues of respectful care. How can that be transferred, for example, to maternity care and provision of maternal services in hospitals? So I think there's a need to join the dots, and perhaps this is something that the work can further advance and encourage cross-fertilization and learning, given often these programs exist in the same physical environment as well. And finally, it's important to think about metrics of success, and this ties to the point of small wins are big wins in this context. So what are the bars and measures of success we should be using, but also thinking about scale and sustainability with these programs. Next slide, please. And I just wanted, in terms of missed opportunities, to finish on this point around a lot of the work that was being done across the case studies involved voluntary work. And I think gender integration, advancing gender equality in health cannot be seen as an optional. And in environments where resources are being cut, it's really essential that these pieces of programs, of health programs, are seen as core and central and are matched with commensurate commitments, whether they be financial, whether they be human resources and personnel resources as well. Next slide, please. And just to finish, I know I'm out of time. How can we build on this work? And I think this is a really important piece to recognize. What we don't want as an institute and as a research collaboration is to stop here. These are not just reports to sit on a shelf. We very much want to continue working with national partners, but also sharing the transferable lessons to advance this agenda. Recognizing, and I think this is something that has come up across the case studies, is a lot of the work in these scaled and sustained programs have been a marathon and not a sprint. And so we need to keep that momentum going, continuing to build collaboration, both in terms of South-South collaboration, but also multi-sectoral, thinking about continuing to co-create this practice-based evidence. What does it mean? What else, what other evidence can we generate and leverage? Thinking about better engagement of key champions, both inside government as well as outside, to sustain that momentum. And finally, communication. How do we communicate some of these key pathways to change and strategic framing of issues to advance this agenda? So on that note, I will stop here and thank you very, very much for joining us today to launch these case study series. Please do visit our website. I did want to hand over now to my colleague, Professor Asha George, who will be moderating the panel discussion today. Asha doesn't need a long introduction. I'm sure many of you know her, and she has been an absolute pleasure to work with as part of this project, in addition to all the fantastic partners we've had with us. So Asha is a professor at the School of Public Health at the University of Western Cape. She's also the South African Research Chair in Health Systems Complexity and Social Change. Asha, over to you.
Delighted to be with you, and I think this is a great start. We really had an kickoff from Professor Naila Kabir, who really in the 1990s gave us some of the initial thinking and framing of how do we integrate gender into policies and programs. So this is a touch point for how has been a key reference point for our work. And Joanna, both of them gave you an overview of the studies. We won't be going in through all the studies, but we're hoping to give you a better sense, an in-depth view of 3 of the case studies. And we encourage you to go look up more from the through the links provided. So we are going to have an engaged conversation to share some of the expertise and learning from the case study in Niger, the École de Marie initiative with Aissa Diarra. And then we will also compare that with the lessons from the Philippines on how gender was integrated in the Baguio General Hospital and Medical Center. And then we have a colleague from Nepal who will speak to their reflections on how they mobilized to change impact at the macro level legislation on safe abortion as a key aspect of integrating gender into national frameworks. So let me, before we jump into the panel conversation, I will just formally introduce our colleagues from each of the case studies. We have from Niger, Dr. Aissa Diarra. She's a researcher from LASDEL, which stands for Laboratory for Studies and Research on Social Dynamics and Local Development in Niger. She's in charge of the Health Division. And, sorry, I'm delighted so many of you are answering the poll. She's in charge of the Health Division, and she's an expert in sexual and reproductive health issues in Africa, with a broad focus on health policy and systems and power relations. She led the Niger case study. From the Philippines, we have with us 2 colleagues, Maria Christine Josefina Balmes. She's the Deputy Executive Director for Operations for the Philippines Commission for Women. She has extensive experience in government service and has consistently advocated for the promotion of gender equality and women's empowerment in health. And she's accompanied by Dr. Jennifer Joseph Curry, who's an associate professor in anthropology at the University of the Philippines. JJ is a feminist researcher and activist doing pioneer work on gender and sexuality studies, indigenous studies in the Philippines, and was also the lead for the Philippines case study. Lastly, we have, but not least at all, we have Dr. Deb Shrestha Dango. She's the head of Department of Health Systems and Policy at UNU-IIGH, Nepal, where she played a key role in ensuring clinical compliance, working with partners, and really engaged in many ways in providing evidence-based and technical support for policy formulation and implementation for safe abortion. So there we have it. We have 4 colleagues. They should be coming online. And I see from the participants, many of you have worked, quite a few of you. Should I be sharing the results? Have worked with gender and health. Should I press share results or would someone else do that?
I can do that, it's okay.
Okay, great. So that's the first question. And I don't know if we also asked a second question on gender mainstreaming health. Maybe that can happen in the background. Well, let's get started. I'm delighted to have all 4 of you to join us, and maybe starting with Aissa to think of, as Naila Kabir said, these programs are counterculture. They are changing culture and are working against the grain. So maybe each of you could speak to what triggered change. How did these case studies start? So maybe starting with Aissa, and we can go to Christine in the Philippines and Deeb in Nepal. If you could share your thoughts, what do you think was critical in starting the process of change in your context?
Bonjour tout le monde et merci Asha pour cette question. Je suis vraiment très heureuse de pouvoir partager les résultats de l'étude que nous avons menée au Niger sur le programme d'initiative qui a été vraiment très prometteuse, qui s'appelle l'école des maris. Alors, il faut dire pour répondre à votre question que nous sommes dans un contexte au Niger où le taux d'utilisation des services de santé maternelle, de santé sexuelle et de santé maternelle sont assez bas. Les femmes et les jeunes filles utilisent peu les formations sanitaires, les services de santé maternelle. Et il se trouve aussi que nous sommes dans un contexte où nous avons une forte résistance des communautés vis-à-vis des programmes de santé sexuelle, notamment l'utilisation des contraceptifs modernes. Cela est une chose. Il faut aussi dire que l'autre point en dehors du contexte, de ce contexte sur les indicateurs sanitaires au Niger, c'est aussi le fait que nous avons un fort engagement communautaire. Donc, cela a été vraiment un point fort dans le déclenchement de ce programme. Autre chose aussi, c'est que nous avons au niveau du Niger un engagement au niveau des ONG locales. Donc, les ONG locales sont très engagées et cela a aussi été un élément assez fort. Autre élément, finalement, pour terminer, c'est le rôle majeur de l'UNFPA à travers notamment un responsable au niveau de l'UNFPA qui a vraiment pu mettre en place, intégrer d'abord l'idéologie de l'initiative École des maris, mais aussi faire en sorte que on ait vraiment une implantation de l'EDM au niveau du Niger, et cela à partir de Zinder, mais finalement sur tout le territoire nigérien. Merci.
Thank you, Aissa. I think you've answered by saying it was a constellation of factors. It wasn't just one thing. It was the recognition of key need, a huge gap in terms of service delivery and women's rights and needs, but also recognition of resistance in terms of the culture and how do you overcome that. And we'll come back to you in terms of issues of scale, how having NGOs who could assist from the outside as well as donor support help move these things. Let's hear from the Philippines. Christine, what were some key things that catalyzed change and set things going in your context?
Thank you, Professor Asha, for that wonderful question. I hope you can hear me clearly. I'm at the COP28 in Dubai right now, and it's very crazy over here. So international and national commitments, which led to enabling policies and mechanisms in the Philippines, may be considered as the factors that set off the initiative to mainstream gender, not only in the Baguio's General Hospital and Medical Center, but in all government agencies and instrumentalities. For one, we are committed to the Sustainable Development Goals, which aims to ensure, among others, that we work hand in hand in advancing gender equality and that quality healthcare is made accessible to everyone through the Universal Health Coverage or the UHC. But even prior to the SDGs being adopted, efforts to acknowledge women's role in the Philippine society and to address gender issues have already started to take shape. So as early as 1975, the Philippine Commission on Women, then known as the National Commission on the Role of Filipino Women, was established as the first national women's machinery in the whole of Asia. This was the Philippine government's response to the UN General Assembly's call for member countries to establish government machinery to attend to women's concerns. So the Philippines became a signatory to the Convention on the Elimination of All Forms of Discrimination Against Women, or the CEDAW, on July 15, 1981, ratifying it on August 5 of the same year. So gender-responsive budgeting, on the other hand, was first introduced in the Philippines as early as 1992, when the then NCRFW and then now the PCW lobbied to include the women's budget in the Annual General Appropriations Act. The women's budget eventually made its way to the general provisions of the General Appropriations Act, directing agencies to fund and implement gender advocacy and women's empowerment initiatives amounting to this was eventually fully institutionalized in Republic Act 9710, or the Magna Carta of Women, in 2009, and further mobilized through the joint agency circulars on the preparation of the annual Gender and Development Plan and Budget and localization of the Magna Carta of Women. So the country's bold legal and policy frameworks at the nexus of gender and development and health may also be gleaned from the following salient legislation, such as the Responsible Parenthood and Reproductive Health Act, the first 1,000 Days of Life Law, also known as the Kalusugan and Nutrition ng Magnanay Act, the 105-day Expanded Maternity Leave Law, the Philippine HIV and AIDS Policy Act, and the Universal Healthcare Act. So, as in the case of the Baguio General Hospital and Medical Center, the driving force for deliberately mainstreaming gender in this institution often comes not only from the existing policies and enabling mechanisms, but also from the goal to adequately cater to the community that they are serving. So, as the biggest tertiary hospital in Northern Philippines, with a capacity of 1,200 beds, over 15 different medical departments, and catering to a large migrant community, the LGBTQIA+ community, and the different indigenous ethno-linguistic groups that continue to practice aspects of their culture in varying degrees, provision of gender-responsive and culturally sensitive healthcare in the PGH-MC is not a mere suggestion, but a necessity.
Thank you so much for sharing and really showing how far the journey has taken. You know, starting in 1975, how these steps over time, it's an iterative process of putting in these stepping stones or these foundations for the change that you're seeing now. And also listing key elements of architecture, budgets, and how you break it down to successively, progressively, I'd say, build the architecture to support the change in Baguio General Hospital. That's very helpful to understand. Perhaps we could go to Nepal and just listen to, in Nepal, clearly in the Philippines, international commitments and national legislation helped so much. We're going to hear from the Nepal case study. They were working on national legislation. So how did we get legislation that was more responsive to women's needs and address gender transformation in your context? What were key catalysts? Thank you.
Thank you, Asha. So talking about Nepal, can you hear?
Yes.
Yeah, okay, thank you. Okay. So before 2002, when abortion was really restricted based on the Nepal's legal code, and the woman could not have abortion under any circumstances, classifying it as an infanticide, and many women had to go to prison if they had an abortion. So this led like women seek unsafe abortion that carried high risk complication. So and at that time, Nepal's maternal mortality ratio was very high. It was about 539 deaths per 100,000 live births. That attributed to unsafe abortion. And then it was the third leading cause of maternal death in Nepal. So due to, and because of, there was some facility-based studies carried out where there was like 20% of maternal death were due to non-legal abortion, and more than 50% were obstetric complication admission due to unsafe abortion. So I think as a provider, I have seen before the legalization and after the legalization, because I was working in one of those tertiary hospitals where unsafe abortion was were treated, and we had seen like women were coming into for emergency treatment because they had some sticks inserted into the uterus or taken some dangerous herbs. So that really like affected the family members also, and because another is like about 1/5 of women in Nepali prison were convicted because they were based on non-legal abortion. So many of the women were in prison at that time. So because of the major cause of maternal death, along with the emergence of national and international women's right movement, there was dire need to advocate to reform the Nepal's restrictive abortion law. So for this, I think it was the diverse partnership that really led by the government of Nepal with members from international and local NGOs, advocacy group, private partners, and professional organization. And I think IPAS has been with the movement from the start of this. And on 14th March 2002, it was legalized and approved that abortion can be performed after 3 decades. It was not an easy task. It took around 3 decades for the reform efforts. So under this law now, like at that time, abortion was permitted, and based on the gender equity, I think abortion can be provided only with the consent of the pregnant woman. You don't need the require the partner's consent on that. You can just have the woman consent to take the abortion services, and you cannot coerce the woman to take abortion. And another is the sex selection abortion is prohibited, and abortion should be confidentiality, should be maintained by the facility that provides the services. I think all this really triggered the abortion law in Nepal. So thank you for that.
Thank you very much. To sort of similar to Niger, how evidence on the extreme health effects in terms of maternal mortality, whose health and rights were being affected, but also the coalition of actors that came together and that mobilized. And you're saying three decades of concerted effort to realize this change. Was someone trying to jump in? I think we have the results. Did I hear it? No. Okay, we have the results of the second poll. So many of you do have experience working with trying to integrate gender into larger programs. So we look forward to learning from your experiences as well. We're about halfway through our discussion, and I wanted to, many of you in your question answers already responded to issues of scale. And one of the reasons we selected these programs is they weren't just small projects implemented by NGOs. They really tried to affect change at a large level. Aissa, anything further you'd like to add briefly on what were key elements to really sustain this change at scale in Niger and get that buy-in?
Oui, merci Acha. En fait, il y a vraiment au Niger sur cette initiative un fort engagement des services gouvernementaux. L'école des Maris a été structurée de telle manière qu'elle soit articulée au ministère de la Santé. Donc, nous avons au niveau du ministère de la Santé donc cette articulation qui fait en sorte que nous avons un maillage vraiment important de l'EDM à travers le système de santé. Cela est une chose. Aussi, il faut savoir que cette intégration dans le système de santé est visible à travers les plans d'activité annuels que nous retrouvons dans les programmes des formations sanitaires. Ensuite, il faut dire que l'UNFPA, qui a eu vraiment un rôle important dans la mise en place, dans l'élaboration et la mise en place de l'école des Maris, a mis à la disposition justement de ce programme un dispositif assez important, par exemple la mise en place de cahiers de suivi pour l'évaluation et le suivi du programme, et cela autant au niveau institutionnel dans les formations sanitaires, mais aussi au niveau local où nous avons des ONG locales qui se sont déterminées dans la mise en œuvre et la mise à l'échelle même du programme. Sur ces ONG locales, il faut reconnaître le rôle vraiment important d'une ONG locale qui s'appelle Songe, qui a permis, grâce à sa compétence, qui a dû relever le niveau de sa compétence pour capter justement les financements internationaux. Et donc, Change a vraiment pu, à travers ses coachs, puisque les coachs sont apparus dans le programme EDM comme des acteurs très importants qui sont vraiment à l'interface entre le programme École des Maris et les communautés. Donc, ce sont des observateurs, à la fois des observateurs extérieurs qui ont vraiment une certaine maîtrise même de la mise en œuvre des programmes sanitaires, mais qui sont aussi implantés au niveau des communautés, puisque ce sont des coachs qui vivent avec les communautés. Cela est une chose. Autre chose aussi, c'est que il faut vraiment mettre en évidence cette réalité dans un pays pauvre comme le Niger, qui est fortement dépendant de l'aide extérieure. Et cette dépendance fait en sorte que les subventions sont parfois, les subventions financières par exemple, sont parfois insuffisantes, ou alors il y a vraiment une rupture des financements. Et cela, il faut dire que cela a été un des défis dans la mise en œuvre de l'EDM, puisque durant une période, il y a eu vraiment une baisse des financements. Et cela a fait en sorte que au niveau du système de santé, nous avons eu vraiment une résilience des agents de santé qui sont vraiment à l'interface des programmes de santé et des usagers, et qui font vraiment, qui développent des solutions que nous appellerons des solutions endogènes pour que justement il y ait une continuité de l'école des Maris. Donc vraiment, il a fallu vraiment cet engagement fort au niveau du système de santé. On peut aussi mettre en évidence le rôle du ministère de la promotion des femmes, puisque il y a vraiment ce rôle qui a fait en sorte que nous ayons vraiment la prise en compte des éléments de genre dans la mise en œuvre de l'EDM qui au début n'était pas vraiment considéré, puisque nous avions, comme on le voit dans la plupart des EDM qui ont été implantés ailleurs, cette confrontation, cette tension entre le ministère de la Santé et le ministère de la Promotion des femmes. Donc, l'engagement du ministère de la Promotion de la femme fait en sorte que nous ayons vraiment l'intégration de certains aspects liés au genre, tels que le renforcement de la capacité des femmes à négocier les décisions liées justement à l'utilisation des services de santé sexuelle et reproductive, mais aussi à faire en sorte qu'elles puissent vraiment trouver vraiment des espaces de liberté. Donc, nous avons vraiment ces différents éléments qui ont fait en sorte que nous avons vraiment une forte implantation et une mise à l'échelle de l'EDM. Autre chose, finalement, c'est que il faut reconnaître que l'école des maris est une originalité en soi, puisque jusque-là, nous avions des programmes de santé sexuelle et reproductive qui sont focalisés sur les femmes sans vraiment prendre en compte le rôle important des hommes qui sont vraiment déterminants dans l'utilisation des services par les femmes. Donc, je pense que cette originalité, justement, de l'EDM a été vraiment, a fait l'objet d'une forte inspiration par d'autres ONG internationales qui ont pu contribuer à la mise à l'échelle de l'EDM. Merci.
Thank you, Aisa. So much to share. I'm not sure we're really doing justice, but it's good to hear from the different contexts. And one thing that struck me about what you said is, Nyla said these are counterculture disruptive or interrupting business as usual. But clearly a key part of going to scale in Niger was becoming business as usual, integrating it in the Ministry of Health and the training programs in Philippines, the budgetary processes, the annual training. Maybe a few words from JJ from the Philippines. What do you think were key elements working with the Ministry of Health, which was clearly a key part of Niger's case study? What do you think were key elements working with the hospital to really take this to scale across the hospital?
Hi, can you hear me?
Yes, go ahead.
Okay. In Baguio General Hospital and Medical Center, the role of gender champions and a very dedicated staff, although very small but very committed staff, have become very important in gender mainstreaming. For example, a gender champion started the implementation of gender mainstreaming in the hospital, but it was picked up and intensified by the current chair of the technical working group of the gender GAD focal point system. And she is supported by, as I've said, very committed and very knowledgeable staff. The approach has been more institutionalized. The gender GAD focal point system is composed of 42 members, representing all the medical units and administrative units, so that the gender focal point system can be implemented properly. They conduct regular meetings, gender planning and budgeting, monitoring the implementation of all the plans and the budget. Since 2016, the GAD focal point system has been institutionalized. While, for example, other government institutions cannot meet the 5%, the minimum 5% budget for GAD, the hospital, the Baguio General Hospital and Medical Center, in 2022 has reached 20% GAD attribution of their budget. Of course, this was made possible also by with the support of the medical center chief, who provided the budget, the staffing, and support for all the programs really relevant to gender mainstreaming.
Thank you, JJ. People power. Having key champions and having them really committed to the planning process, going from a minimum of 5% to 20%, taking advantage of resources, really striking. From Nepal, Deep, what do you think were key elements? You talked about what started the change, but what were things that sustained it over time to be able to change legislation from your perspective, please?
Okay, because like safe abortion service, like it in Nepal, after being approved, it really was phase-wise expansion was there. So it was basically was to save the woman's life mostly in the vulnerable and remotely disadvantaged. So for this scale up, like there was like commitment from of the Nepal government, along with the sound planning and implementation with the different partnership. And there was also another was like the sustaining or the scaling up was like because there was already a Safe Motherhood Initiative program. And so integrating abortion into the Safe Mother Initiative was another foundation for the success because there was already some providers who were already there to provide the services. Of course, like you need to have a training. And another was like female community health volunteers there for information and referral to facilitate to integrate safe abortion in the existing health system. So that was another important foundation. And another was the legality, like it started with using the manual vacuum aspiration, which was used 1995 to treat incomplete abortion. Of unsafe abortion, there was already a manual vacuum aspiration that was taking place just to treat those post-abortion complications. So already the providers were well acquainted with this procedure also. Another was like there was the task shifting because it only provided to the doctors, and later it also task shifted to the ground level, like we say that like auxiliary nurse midwives, which are like the community based providers in the community level. So I think it was a really very bottom down. The scale up was also gone down to the community level because we wanted to reach the most vulnerable people. Because when the law was there, it was mostly in the urban area, and later it shifted to the mostly into the remote areas through medical abortion also. And then because of this, previously it was chargeable, and now like after in 2016, like free abortion service was provided as it was one of the basic health services in Nepal. And then we also had like during the COVID also, because the abortion service was not really very, so there was also like the reproductive maternal neonatal child health guideline was also there. So all of this act and guidelines was guided by the 2015 Constitution of Nepal, which guaranteed that safe motherhood and reproductive health right should be the right. So this was basically how it was scaled up. And beside that, there was the systematic data at the facility and the central level also. Because of this, like before we had that 500 plus maternal mortality, and now like it has gone down to 151 per 1,000 live birth. And because at that time, due to maternal death due to abortion was 7%, and now it has decreased to 5%. So I think we have seen that changes because of this scaling up of abortion service in Nepal. Right, thank you.
Thank you for sharing and the huge impact that it's made on access to health services, which has also been the case in Niger in enacting these changes, and also sharing how systematic you followed up the phases of change from guidelines, training, across the health system. Really fascinating. We have less than 10 minutes and so much more to share. So I'm going to combine the next two questions, which I think in our discussions, we were thinking about accountability. Now that you have started the change and you've sustained it, or, you know, it's a change that's not in a small area, but really across the program, across the hospital, across regions, or the whole country. What do you think is critical in terms of accountability or accountability systems to ensure that that change happens in the long run? And what do you think are the future steps that you'd like to see to really ensure gender transformation? Let me start in reverse order, since we've always been starting with Niger, maybe to give Deeb a chance. First to you. Your thoughts, please.
Regarding the accountability that is needed to sustain gender integration in the government system, I think one thing is like it should be like guided by the policy framework and the leadership, right? However, like I think individual level also should contribute to the change that focuses on the internal culture for gender equity and equality in our daily life also. We also should not only depend upon the government system. It should come within ourselves, people. So I think we should start by ourselves first, right? So coming to the question to sustain in the government system, I think we need to have a meaningful participation of the women representatives, like we see like in the parliaments, in the local level, because now we have like 3 level of governments in Nepal, and the local level, the elected women members are just coming up, and we don't see much of those like meaningful participation. I think the meaningful participation of them is very necessary, so as to because they are the decision making bodies, we should be meaningful. And so I think one is the capacity building of these parliamentarians, and the local elected women elected also should be there. And I think we should have like a women's advisory group or committee to provide input on the policy development, because anytime, sometime the policy. So to have it sustained, I think we need some women advisory group or committee to be have the sustain this gender integration in the government system. And another is conduct like outreach campaign to encourage women's participation, public consultation and hearing also. Like you should have a public hearings, like whether gender is really integrated or not, because the framework, the policy, it might say yes, there is. But what about the woman that really is needing that service? Are they receiving or not? So I think those public hearings should be there, so that the policy people also should know, like it doesn't work if there is only policy, there should be implementation also. And another I think is the gender responsive budgeting, right? Because like even in the health system at present, the government budget is so less. So what about the gender responsive budgeting? Is it enough? Is it what that we have really required is there or not? Also there. And another is the conduct gender analysis there. And another is gender disaggregated data. Yes. And maybe like it should not only depend on the public sector, but also private sector should be equally responsible for this policy. So I think that is really very important, and the monitoring system by the government is also important. Thank you for that.
Thank you, Deeb. Really, you brought out not just the leadership and budgets, which has come before, but the politics, making sure there's pressure from outside, women elected leaders and the advisory groups. This is just the closing segment because there are a lot of good questions from the participants. So maybe first Christine and then JJ, what do you think from your sense are key elements of accountability and next steps for you in the Philippines?
Oh, I think Dr. Deeb has shared a lot already, and we do believe in the same things that she thinks will make this gender budgeting and gender mainstreaming sustainable. But in the Philippines, what works is the Commission on Audit that does the regular auditing of national government agencies as well as local government units, and they are ensuring that the minimum 5% utilization of the gender development budget is implemented, and they are also being held accountable if they do not comply with the minimum 5% budget utilization. They also not only focuses on the financial aspect of this gender budgeting, but as well as on the implementation of the gender and development plans, programs, and activities. I think that really works well for us.
Thank you so much, Christine, for reiterating some of the key points that have been shared. JJ, any last thoughts before we go into the Q&A in terms of accountability and next steps?
Yeah, just one point. If we are really serious about gender mainstreaming and we want to replicate this better or best practices, we need to create God-devoted positions in all government institutions, not just in the Philippines, so that God work will not be just add-on or additional work for all those who are doing God work. That's it.
Thank you. Dedicated champions who are funded and rewarded for their work. Very helpful. Aissa, thoughts from you in terms of accountability to really ensure gender transformation in a program like École de Marie?
Oui, je pense que ce qui est clair, hein, l'école des maris a fait la preuve que en mettant en œuvre cette initiative, il y a une forte amélioration des indicateurs de santé sexuelle reproductive. Il y a aussi, c'est une preuve que des changements de mentalité. Mais effectivement, il reste des défis. Et depuis 2008, ça fait donc, nous avons à peu près 15 ans de mise en œuvre de l'EDM. Donc, nous avons vraiment eu un recul par rapport aux défis rencontrés dans la mise en œuvre de l'EDM. Donc, ces défis nous montrent qu'il faut vraiment qu'il y ait une forte responsabilité au niveau du ministère de la promotion de la femme, puisque depuis sa création, c'est surtout le ministère de la Santé qui prenait le pas sur le ministère de la promotion de la femme. Donc, il est important qu'il y ait vraiment la mise en place d'un dispositif assez fort au niveau du ministère de la promotion de la femme pour que ce ministère puisse trouver sa place dans l'initiative École des maris. Autre responsabilité, c'est la responsabilité au niveau communautaire. Nous savons que très généralement, nous sommes dans des sociétés qui sont dans le monde du développement, qui sont très attentistes, qui attendent beaucoup de l'extérieur. Je pense que l'EDM a apporté un changement par rapport à cette vision, mais il reste encore vraiment des défis à relever à ce niveau. Actuellement, l'EDM est en train d'être articulé au niveau communautaire sur les chefs de canton. Effectivement, les chefs de canton, comme on le dit sur le terrain, ce sont des acteurs restants. Donc, ils restent par opposition aux acteurs qui partent comme des ONG internationales ou des ONG nationales qui ne sont pas vraiment au sein même des communautés. Je pense que cela est important à relever. Autre chose aussi, c'est que il faut qu'il y ait une responsabilité au niveau des femmes elles-mêmes, puisque on parle d'une approche de genre. Et quand on parle d'approche de genre, il est important que ça soit à la fois que tous les genres soient représentés. Or, dans l'EDM, nous n'avons que des hommes. Donc là aussi, c'est comme si on ne peut pas avoir de mixité. Donc, il est important d'avoir cette mixité dans la stratégie EDM. Mais là aussi, il faut faire attention, puisque ce qu'on a vu jusque-là, les organisations internationales qui ont eu à faire cette mixité, c'est que les normes de genre reviennent encore pour mettre en cause cette mixité, puisque lorsque des hommes et des femmes se rencontrent dans la mixité, ben, la détermination de la place de chacun vraiment est du ressort des hommes. Donc là, c'est un défi à relever si nous voulons vraiment cette forte intégration des hommes, des femmes aussi. Merci.
Thank you, Aissa. I think that's a provocative ending in terms of how far we've come, the progress that's been made, but the ongoing negotiation that happens when you're dealing with power relations in really integrating gender into programs and really bringing in multiple stakeholders and changing power between men and women. Let me hand over. I think we have a number of questions. We're not finished, but we do want to engage those from the room who have been posting questions. Let me introduce my co-moderator, Professor Srilata Rao Sheshadri. She's the director of the Ramalingaswamy Center for Equity and Social Determinants of Health at the Public Health Foundation of India, and has been a key partner in this collaboration. I know we've gone over time, but over to you, Srilata. I think there have been many questions. Thanks very much, everyone.
Thank you, Asha, and thank you to all the panelists for such an interesting discussion. And without further ado, I don't want to delay getting into the question and answer session, because there are several questions from the participants in this session. We have one, and this is particularly, I think, directed at Christine, but also this was mentioned by Deeb, I believe, about gender responsive budgeting. And the question is that is from Puleng Letsi, who asks, it will be interesting to hear some concrete results of the GRB from countries which started some years back, like Nepal and the Philippines, and what has changed structurally, institutionally, and socially. Perhaps, Christine, you could go first, and then Deep could add her views. Go ahead.
I think for the Philippines, the greatest impact that this gender budgeting result is that we are the 16th in 146 countries in the World Economic Forum Global Gender Gap Index. So this shows that what we have been doing since 1975 is effective. Actually, we've rose up to number 8 in the previous years, but because a lot of other countries are advancing their gender mainstreaming efforts, we are sliding down little by little, but that does not stop the Philippines from still pushing for doing our gender mainstreaming efforts. Another result that I think we could share is that we are giving awards or rewards to government agencies that have notable programs and projects and are truly utilizing their gender and development budget in a way that it impacts our women and girls up to the local or the grassroots level. So you can check them out at our website, ecw.gov.ph.
Is it just me, or has Christine?
So that we can check the how they implement things. Thank you.
Thank you, Christine. Very important lessons from the Philippines on how to institutionalize a very powerful tool, I think. Deep, if you would like to add to this.
Sorry?
Would you like to add? You had mentioned GRB as well, and I think you have some experience as well in this area.
Well, actually, I really don't have a direct experience on that, but we know like the gender, there is a gender budget audit, and that is mostly in awareness raising programs that started in 2005 and 2006. And then later, like it was, there was a committee formed for this gender responsive budget committee was formed in the government itself. And so this was like based on their guideline, the gender-based response, the gender response budget is planned. Not really very clear like how much budget has been there. Thank you.
Thank you. I think this is possibly an important takeaway for us as well on how, on accountability mechanisms that could possibly work. We have another question from Tanya Jacobs, which is quite different. Perhaps each of you could take a minute to respond to it, which is, can you share your thoughts on how you dealt with backlash and anti-gender equality actions and movements? And maybe we can start with JJ and then go on to Aisa to reflect on this.
Yeah, the Philippines, despite all the gains we've had in gender mainstreaming, is still a very conservative country. The Roman Catholic Church and some conservative religious groups still have a very good stronghold on our politics, both the electorate and the politicians. So I think the lesson I learned is I pick my battles. So we try to win allies, but if we cannot win them, we just have to ignore them and push on with our agenda. That's it. I think you'll get burned out if you pay attention to all of this anti-gender or anti-LGBT sectors. So I try to choose which ones I would engage with.
Interesting. This actually, what you just said would possibly lead to our next question, but I will come back to this point later on. Aisa, could you reflect on this? Because you also mentioned that at the community level, there was a lot of resistance to what you all were trying to do.
Oui, en effet, nous sommes dans le même contexte aussi. C'est que il y a des résistances, c'est clair. Et je rappelle que bien souvent, le gouvernement nigérien est confronté justement à ces résistances chaque fois qu'il y a de nouvelles lois qui sont intégrées, donc par exemple l'intégration de l'éducation sexuelle dans le système éducatif. Nous avons eu vraiment des remous d'une forte intensité au niveau du Niger. Je pense que l'école des maris, cette initiative a pris en compte justement ces résistances en faisant en sorte qu'il y ait dans le fonctionnement même l'intégration au niveau des écoles des maris, l'intégration de chefs religieux qui font partie, qui sont membres de l'école des maris et qui vont être vraiment des champions qui vont lutter justement contre ces résistances et qui vont chercher à avoir l'adhésion d'autres chefs religieux au mouvement école des maris. Donc, je pense que c'est une stratégie qui est assez prometteuse et qui fait en sorte que justement on ait cette adhésion des religieux, des chefs religieux. Je pense que dans tous les cas, nous aurons tout le temps ces résistances et qu'il faut faire avec ces résistances et trouver vraiment toujours des voies et moyens pour avoir leur adhésion et non je pense, de les ignorer. Merci.
Thank you, Aisa. Very important. I think it's interesting that both you and JJ brought up the issue of religious leaders. I'm wondering, Deep, did you have the same experience? Did you also face backlash? And was it from any particular constituency that you faced it?
I think like we also do have sometimes like backlash, mostly from the religious community also is there. And then mostly because like after the law is passed also, there was still like some conservation, like the youth and adolescents should not get abortion services. They should like they should not use contraceptive. So like reservation is still there. It's not that it's gone because it is still stigmatized, like abortion should not be provided to the youth and adolescents. So I think this type of backlashes has already been there and go on because we still have that patriarchal society, a society where like they don't want these people, like even when if a young rape or incest, they prefer like they should get married to that person instead of having an abortion. So I think this type of like stigmatization is still there in the community.
Thank you. I'm wondering, is there, a way in which you have framed these issues differently to bring different stakeholders on board? Was there any particular strategy that you used for the framing of these issues? Christine, did you have to use a different tactic or a strategy to do this?
Actually, what we do in the Philippines, well, for the Philippine Commission on Women, since we're a policy-making agency, is we come up with women's priority legislative agenda every administration, so that we can gather and look for champions in the House of Congress or in the Senate, so that policies and programs that we would want to implement and that we would want to be passed, we have support. I saw in the chat that engaging allies is one of the strategies. Yes, we do look for champions so that we can help push for the things that we want to happen. There are really a lot of backlash, especially since, as mentioned by Dr. JJ, that we are a very religious country. So in order to counter that, we look for champions, and we do have a lot. Actually, those champions are sometimes the ones that are expecting too much from us to deliver, so that we can have a lot of things to implement, and a lot of really push for gender mainstreaming in the government.
Thank you. I do believe we have run out of time, although we may have time for one last question from Priya, who asks, did you have to compromise your gender inclusion agenda? Some areas were acceptable by policymakers and others were not, for example, and how did you decide to move forward if these were essential areas for inclusion? I think all of you have alluded to this in your own way, especially in answer to the previous question. But if any of you would like to add something in response to this question, we could take a few minutes to do that. Aisa, would you like to perhaps comment on this, whether you had to compromise your gender inclusion agenda in order to make it more palatable to some of the people who were influencing this?
Oui, merci. En fait, le compromis, c'est que le contexte du Niger montre que en termes d'intégration du genre, nous partons vraiment de loin. Nous partons de loin et que les mentalités sont assez fortes, n'est-ce pas, sont quand même enracinées dans l'acceptation de l'égalité des genres. Donc, l'égalité n'est pas pour le moment acceptable dans cette société nigérienne, comme dans tous les pays du Sahel d'ailleurs. Et donc, ceci nous amène vraiment à baisser le niveau de nos ambitions. Nous voulons, en fait, dans le programme, je pense, dans le contexte dans la mise en œuvre de l'initiative École des maris, c'est vraiment l'équité de genre qui est plutôt acceptable. Donc, nous devons vraiment baisser nos ambitions par rapport à cette vision de l'égalité entre les sexes. Merci.
Thank you very much. I think we are at the end of the Q&A session. Thank you so much for a very lively session with sharing all your experiences, and also for your very engaging participation to all those who sent in their questions and who have been part of this discussion. The insightful observations from our panel have really given us a lot of food for thought and also a lot of lessons to take away from this session. The positioning of gender equality as a prerequisite for sustainable development and health has resulted in significant gains, as we can see from the experiences that were shared just now. However, there have been setbacks as well and backlash. And of course, the recent COVID-19 pandemic showed us that there are huge gender disparities in access to healthcare. But it is generally understood that gender integration in health programs would substantially address health inequalities. But how? This set of case studies has really helped to shed light on what is possible. And as Sagri and Professor Kabir stressed, how to make it happen. The whole process of putting these case studies together has been reflexive and collaborative. It has been a rich engagement and also a complicated journey to come to where we are today. But this has been an excellent opportunity, I think, to share what we have learned through this process and through this journey. As you can imagine, it hasn't been a smooth one. We've faced many challenges, but I think our discussion today has really helped to unpack some of what we learned as we went through this process. The first question I think that we wanted to address through this set of case studies is, what value will this project add? Are we going to be able to develop a roadmap to gender integration or to gender mainstreaming? As we discussed that as well. Which one should we be thinking about? But what our discussion has shown and what our case studies have also illustrated is that each of these case studies has its own trajectory, its own narrative, and gender inequalities are socially determined and they're deeply rooted in power dynamics that are specific to each context. And this is what we've heard from our panelists as well. And negotiating these contextual differences requires a long-term and sustained effort by multiple actors. Secondly, how do we measure success? At the outset, what we were clear about is that we don't want to call it best practices. We deliberately called it promising practices, because what our discussion has shown that is that here again, success is relative. And as Joanna said in her presentation, it's not a sprint, it's a marathon. So when we try to measure its success, will make a big difference. The third big question we tried to grapple with was, why focus on the government? What we have found is that the government can be a real game changer at a scale that is otherwise not possible. Through various instruments, including the Constitution, as we saw in Nepal, through national policy, active collaboration, as we found in Niger, and specific programs like the gender guidance clinics in India. Also, what we found when we started looking for evidence is that there's a big gap in evidence. And so generating evidence on how governments have grappled with this idea of gender integration is a really key contribution of our work. And finally, of course, what we have seen is that change is possible. In each instance, of course, it's been the result of sustained effort, and it has needed advocacy and goal setting at the global and national levels. It has needed champions, gender focal points, for example, as JJ mentioned. It needed the voluntary efforts of innumerable people who acted in response to a need. And of course, the day-to-day service of countless individuals within the system and outside it. But we have tried through this project to recognize a small but significant set of such efforts. And we need to remember, again, that there is a lot of work yet to do. We need more evidence. We need to look at things like intersectionality. How does gender inequality intersect with other sources of inequality? And so many other questions like that. And I do hope that this effort will continue and that it will continue to be supported as well. As Joanna said, and I repeat, it is a marathon and not a sprint. But before we close, please, I'd like to remind you all to look out for forthcoming publications related to this work in the coming year, which includes a consolidated analysis, reflective piece on the process of case study identification and selection, as well as a piece on the national policy dialogues that were held for each case study, where we engaged with key stakeholders in utilizing the practice-based evidence that we had generated. Also, I request all of you to please share your thoughts and reflections on this work via email or social media channels, which are listed in the chat. And we also hope that we can continue to be engaged in this conversation. And to please also, by the way, there is a short survey at the end of this session, which we request you to please complete. Thank you so much for being part of this conversation, and also for participating so actively in the discussion. Thank you.